It's wonderful to have our colleagues from across the country join us. Dr. Hagiwara is an associate professor at NYU Langone Health in New York City, and she's going to give us a talk on conductive hearing loss. So thank you for joining us.
Thank you, and thanks for the invitation, and thanks also to Helen. I know she couldn't make it, but thank you for the invitation to speak as well. I'm going to be talking today on really the imaging workup of conductive hearing loss. And at any point, if you want to ask questions, feel free. But conductive hearing loss, as you all know, occurs when sound waves can't be transmitted between the outer ear and the cochlear hair cells. So any mass occluding the external auditory canal, a perforated tympanic membrane, ossicular abnormalities, including erosions or dislocation, or any soft tissue in the middle ear cavity, that impedes the movement of the ossicles or impedes the movement of the oval window or round window can all cause conductive hearing loss. So abnormalities, again, of the outer ear and middle ear can result in conductive hearing loss, but also abnormalities of the oval window and round window, which are part of the inner ear, can also cause conductive hearing loss, as well as things like semicircular canal dehiscence through the third window effect, which I'll go over at the end. So most of these structures that are affected that cause conductive hearing loss are best delineated on a temporal bone CT. For most pathologies, a non-contrast study will be sufficient, and you want to have very high resolution images. Routinely, we do axial and coronal as well as post-shell views for all of our temporal bone CTs. So just for some normal imaging anatomy, here you can see an axial CT image of the right temporal bone and a coronal. We can see the outer ear here, the auricle, and the cartilaginous and bony external auditory canal. And then you can see the very wispy tympanic membrane, which is normally barely perceptible. If you see it really well, it's probably thickened. And then this is the coronal, also of the right temporal bone, and you can see the external auditory canal, the bony canal medially here, and then you can see that wispy tympanic membrane suprally attached to that pointy scutum. And that membrane is always just a little bit retracted, and we always just make sure that it's not retracted all the way close to or abutting the cochlear promontory. And that tympanic membrane is going to divide the middle ear cavity into three components: everything above, epitympanum; everything deep to it, mesotympanum; and everything below, hypotympanum. And then we have our three ossicles in the middle ear cavity. So we have our malleus, incus, stapes. So if we take an axial CT image up here superiorly, we're going to see that nice ice cream cone configuration of the two ossicles with the malleus head forming the ice cream, and then the body and short process of the incus forming that nice cone. And then as we scroll down, you're going to be seeing the the manubrium of the malleus and the long process of the incus. And so you always want to make sure you follow it down and see those dots coming down. And here you can see it kind of becomes a little vertical as it starts attaching to the tympanic membrane. And so generally when I'm reading a temporal bone CT, I actually just go through each ossicle individually. So I'll find the ice cream cone, and then I'll scroll down and I'll look at the malleus first, follow it all the way down to the tympanic membrane. Oops. And then as I go back up, I'm going to look for the incus again, find the body, short process, follow the long process down, and then make sure it goes to the stapes head. And I emphasize this point because I think a lot of people, they get satisfied with seeing the ice cream, and then they kind of forget to look down. And very often, I think the most commonly missed ossicular erosion that I've seen is the erosion of the long process of the incus. People just kind of miss that because this is, sort of satisfaction of search. This looks okay, and then this is actually missing. For the stapes is oriented upward, and so we have to follow it over multiple axial images. So here down at the bottom, we find the junction between the lenticular process of the incus with the stapes head. And then as you scroll up, you can see a little bit of the stapes anterior and posterior crura. As you scroll up a little bit more, you see more of the anterior and posterior crura. And as you scroll up more, you can see where the foot plate is attaching to the oval window. Coronal image, I always tell our trainees to always try to find this coronal image, identify it. And so here you can see this is the lateral semicircular canal projecting out laterally. Just below that is the tympanic segment of the facial nerve canal. Down below, we have the cochlear promontory overlying the cochlea. And in between where this inner ear meets the air, that's going to be how you identify your oval window in the coronal plane. And I usually just tell our trainees to always just kind of get used to what it looks like normally and its relationship with the tympanic segment of the facial nerve canal. For the round window, it's easiest to identify by identifying the basal turn of the cochlea in an axial image, and then looking back and seeing where the basal turn meets air. That's going to be your round window. And just behind that is the round window niche. Okay, so Pochel view is that view that's obtained parallel to the superior semicircular canal. And as I mentioned, we obtain this on all of our temporal bone CTs, and it allows us to see the superior semicircular canal in its near entirety, which you can see nicely here, and you can see the nice bony covering of the semicircular canal. And it's also just an image to beautifully see the ossicles. So here you can see the malleus coming down to the tympanic membrane, and here you can really nicely see the incus giving this little check mark appearance with the long process of the incus coming down, and then the lenticular process curling up to go to attach to the stapes head. Okay, so now moving on to pathologies. So EAC atresia and infections like otitis externa and necrotizing otitis externa can cause conductive hearing loss, but these entities are usually pretty clear clinically, and so in the interest of time, I'm going to be discussing non-painful, non-infectious causes of conductive hearing loss in the adult patient. And so in the EAC, we have bony lesions, which include EAC exostoses, osteoma, fibrous dysplasia, among others. Soft tissue, we have cholesteatomas and neoplasm. So starting with exostoses, this is the most common benign tumor of the external auditory canal, and you get circumferential narrowing of the canal by these hyperplastic bony protuberances. And it's called surfer's ears because it's thought to be due to repeated cold water exposure. And because both ears are being exposed to the cold water, we usually see it bilaterally. And these are typically asymptomatic until there is enough narrowing that results in conductive hearing loss. These can also trap cerumen and debris and cause conductive hearing loss that way. And these are typically, as you know, surgically resected. And so on imaging, this is what we call an ant mini. Like once you see it, you know it, and you can identify it. And here you can see it has this very classic appearance where you see these bony protuberances, these sessile bony protuberances, again, typically bilateral, and you can see it markedly narrowing the EAC lumen bilaterally. And this is just another case, axial and coronal CT images of the right temporal bone. You can see that characteristic sessile bony protuberance along that bony external auditory canal. And in this one, you can see that there's associated trapped soft tissue that's occluding that EAC lumen. Osteomas, in contrast, they're less common than exostoses, and these are typically unilateral, focal, and pedunculated. And so you're going to see them usually one side, and they just kind of look more kind of elongated, unlike the last case where they were really sessile bony protuberances. And these are also typically, will only cause conductive hearing loss if they obstruct the canal enough, or if they obstruct by trapping some soft tissue behind it. And these are also typically surgically resected. Fibrous dysplasia is replacement of the normal bone marrow by a mixture of fibrous tissue and disorganized bony trabeculae, most commonly seen in young patients. And depending on the ratios of fibrous versus osseous elements, you can have the pagetoid type, which is the most common type, and that's where you're going to see the classic ground glass density. You can have the sclerotic type, where you have predominant osseous elements, and you're going to see some sclerotic foci. And then you can have the cystic type, where you have predominant fibrous elements, and you're going to see lucency And you can see there's this lucency back here with this lesion. So on imaging, we're going to see this expansile lesion with relative sparing of the otic capsule, which you can see here. Again, that ground glass density is very characteristic for the pagetoid type. And then you can have the sclerotic foci for the, lucent foci for the cystic type. And because it's an expansile process, they can narrow the EAC. They can also encroach on the ossicular chain and cause conductive hearing loss that way. And so here you can see this is axial images of the right and left temporal bone. And you can see that there's diffuse expansion of that left temporal bone relative to the right. You can see the sparing of the otic capsule, ground glass density, very characteristic for fibrous dysplasia, but this also has a cystic type that's going across involving the clivus here. And then you can even see a little sclerotic type with these little sclerotic hyperdense foci scattered throughout. And then also in this image, you can see that it is narrowing the middle ear cavity and contacting the lateral margin of the incus here. And you can imagine that's going to basically cause conductive hearing loss by restricting the movement of that ossicle. Inferiorly, you can see it narrowing the EAC here compared to the normal side. This is a very extensive case of fibrous dysplasia. You can see it's diffusely involving all of the osseous structures that we're looking at or that we can see on this image, including the bilateral temporal bones, as well as the clivus and the calvarium. Again, sparing of the otic capsule bilaterally. In this case, it's mildly narrowing the middle ear cavity, but not enough to contact the ossicles. But down further inferiorly here, you can see there's marked narrowing of the external auditory canals bilaterally here. For cholesteatomas, we can see these in the external auditory canal. These are typically unilateral, characteristically located in the posterior inferior aspect of the canal. And on imaging, you're going to see a soft tissue mass with focal bony erosion, like you see here on the floor of the EAC. And then these flecks of calcifications within the soft tissue are fairly characteristic for an EAC cholesteatoma. And we'll talk about this more later, but cholesteatomas are pathologically identical to epidermoid cysts. And so with all cholesteatomas and epidermoid cysts, they will not enhance and they'll have restricted diffusion on MR. Typically, MR would not be indicated in these cases. I think you would see what looks like a classic cholesteatoma on your exam, and then on imaging, we would see the erosive changes. But both clinically and on imaging, the differential is a squamous cell carcinoma. And so these are typically biopsied and resected. And this is just another case of an EAC cholesteatoma. Again, you can see the soft tissue mass within the bony external auditory canal, bony erosions. There's loss of the floor here. This erosions along that posterior wall, and then these central flecks of calcifications. EAC carcinomas account for a very small percentage of head and neck carcinomas. Most commonly squamous cell carcinoma, but you can see other skin carcinomas as well, basal cell and melanoma. On CT, we look for bone erosion. MRI, we can look for perineural tumor spread better than the CT, and also intracranial extension. These will typically drain first to the intraparotid and periparotid nodes, so we'll look carefully at those regions, and then also followed by the jugular-digastric or the level 2 nodes. And these are typically treated with a combination of surgery and radiation. And so here you can see there's this large mass replacing the right auricle and filling the right external auditory canal. And on the coronal CT image, you can see that there is bony erosion along the walls of the canal here. This is a very large basal cell carcinoma. You can see it completely replacing the left auricle here and filling the left external auditory canal. It even extended into the middle ear cavity. And then on the bone windows here, you can see frank bony erosion destruction of the mastoid complex and the walls of the EAC, both anteriorly and posteriorly. Okay, so now I'm going to move on to pathologies of the tympanic membrane and the middle ear. And, tympanic membrane is, of course, the outer ear, but many of the pathologies, particularly the inflammatory pathologies of the temporal bone that cause conductive hearing loss involve both the tympanic membrane and the middle ear, and they're often related to Eustachian tube dysfunction and are seen together in the same patient. So the Eustachian tube, as you know, connects the middle ear cavity with the nasopharynx, and functions include drainage of the middle ear secretions and also equilibration of the middle ear pressure with the atmospheric pressure. And so normally the mucosa of the middle ear cavity absorbs the air in the middle ear cavity, and you get this negative pressure. The Eustachian tube opens periodically throughout the day to help equilibrate the pressure. And so if you have Eustachian tube dysfunction, you're going to have chronic negative pressure in the middle ear and retained secretions. And so that ultimately causes a lot of the inflammatory problems that we see involving the tympanic membrane and the middle ear. And so one of the things we can see is retraction of the tympanic membrane here. You know, like I said in the very beginning, it's usually very wispy and thin. You can tell on your otoscopic exam better than we can if there is a rupture. But generally, if there is a rupture, you're going to see thickening of the peripheral portions of the membrane and then a frank defect centrally. But I usually tell our trainees in radiology not to go crazy trying to figure out if there's a perforation or not, because it's much more clear to you, the clinician, the otologist, to see on your otoscopic exam if there's a perforation. But again, as I mentioned earlier, if you see the membrane really well, like you do here, it's thickened. And this one is very thickened and retracted all the way to the cochlear promontory. It's touching the promontory, and you can imagine that's going to impede the movement of the membrane. And again, this here is a perforation. You see a frank defect centrally. Tympanostomy tubes are used to normalize the intertympanic pressure, and we can see that as these two parallel lines within the tympanic membrane, and they'll typically migrate around the membrane and then self-extrude, and every now and then we can see a tympanostomy tube kind of get stuck here. It's caused a little granuloma in the posterior aspect of the EAC. Chronic otitis media, typically we just see like non-specific soft tissue scattered throughout the middle ear cavity. And as I mentioned at the beginning, you know, whenever you have soft tissue that's along the ossicles or along the oval window or round window, that can cause conductive hearing loss. So in this case, you can see that this is that coronal image with the lateral semicircular canal sticking out, the tympanic segment of the facial nerve canal just below that, cochlear promontory below that, and in between, this is where we should see the oval window. And you can see that there's abnormal soft tissue in the oval window niche. Similarly here in the axial plane, this is about where the oval window niche is, and that will impede the movement of the oval window and cause conductive hearing loss in this patient. Tympanosclerosis is dystrophic calcification from chronic otitis media. When it specifically involves the tympanic membrane, it's known as laryngosclerosis. And again, depending on where it's occurring in the middle ear cavity, if it's involving the ossicles in particular, it can cause conductive hearing loss. And so here, this is an axial and a coronal CT image of the right temporal bone. And you can see that there's thick calcification along the posterior and inferior aspect of the tympanic membrane consistent with laryngosclerosis or tympanosclerosis of the tympanic membrane. In this case here, this is also axial and coronal CT images of the right temporal bone. And you can see this here is that ice cream cone, malleus and incus. And so in the lateral epitympanic recess, there's some soft tissue with this associated amorphous calcifications. And so this is consistent with tympanosclerosis, and of course, this can also cause ossicular fixation. And so here again, similarly in the coronal image, you can see the soft tissue with associated amorphous calcifications in the lateral epitympanic recess. And this is just another case, two axial CT images of the right temporal bone. And here we see the ossicles, but just around it, we see all these other little hyperdense dots, just other amorphous calcifications consistent with tympanosclerosis, and then also calcification of the tympanic membrane as well. Cholesterol granuloma is also usually due to Eustachian tube dysfunction with negative middle ear pressure. That negative pressure can cause mucosal edema and then rupture of the blood vessels in the mucosa. That then causes hemorrhage, and then you get this red blood cell breakdown, and then basically this foreign body giant cell reaction. On imaging, you're going to see, just like what we see with petrous apex cholesterol granulomas, it's going to be T1 and T2 hyperintense, reflecting all the blood products as well as the cholesterol crystals. Susceptibility is something that we see. It becomes really dark, black, on certain sequences due to the blood products. And these typically just require surgical drainage. And so here you can see this is a coronal CT image of the left temporal bone. And we see non-specific soft tissue in the epitympanum, maybe going a little bit into the mesotympanum here, some erosion out laterally. On the MR, this is a pre-contrast T1 weighted image, and you can see abnormal hyperintense signal throughout the epitympanum here. You can actually acutely see the ossicles here. The adductus ad antrum is here. This is the mastoid antrum. So you can see all of that is diffusely filled with T1 hyperintense signal, no superimposed enhancement. This was a cholesterol granuloma of the left middle ear and mastoid antrum. Okay, moving on to cholesteatoma. So this is keratin debris in the middle ear, essentially skin in the wrong place. Again, pathologically identical to an epidermoid cyst, lined by keratinized stratified squamous epithelium. 98% of these cholesteatomas in the temporal bone are acquired. Two types, there's pars flaccida type, which is the most common, pars tensa, much less common. So again, I'm sure you all know this better than me, but pars flaccida is at the top. Most of the membrane is formed by the pars tensa, nice and strong, whereas the flaccida, as the name states, is the flaccid or weak portion of the membrane. And so, there are many theories for the formation of cholesteatomas, but one is that, with that negative pressure of the middle ear cavity, you can get retraction of that flaccid portion, the weak portion of the membrane, so the pars flaccida up superiorly. It further retracts over time. And then the theory is that basically that retraction disrupts the normal desquamation process of the tympanic membrane and basically allows debris to become trapped within the pocket and accumulate, expand, and form a keratin plug. And because of that location of the pars flaccida portion of the membrane, these pars flaccida cholesteatomas will typically be located in Prusac space, which is that portion of the superior lateral mesotympanum near the pars flaccida, and then the lateral epitympanic recess just above it. And then because of this typical location of the pars flaccida cholesteatomas, you typically see erosion of the adjacent scutum as well as the adjacent ossicles. And so here we have a classic pars flaccida cholesteatoma in Prusac space and the lateral epitympanic recess. This is a normal one for comparison. So this would be Prusac space here, lateral epitympanic recess. And you can see the clear erosion, the blunting of the scutum compared to the normal one here. With cholesteatomas, we always look for erosion of all of these structures. So again, most commonly scutum for those pars flaccida cholesteatomas, also the ossicles, looking for widening of that addutus ad antrum, that passageway to the mastoid antrum. Look for defects in the tegmen tympani and the tegmen mastoidium. And if it's a big enough defect, we usually recommend MR to evaluate for an underlying cephalocele before you go to surgery. Sigmoid plate, labyrinthine fistula, most commonly, there's fistulization to the lateral semicircular canal, since that's the part that kind of sticks out or projects out into the middle ear cavity. Facial nerve invasion, and then petrous apex extension. So here we have axial and coronal CT images of the right temporal bone, diffusely opacified by the soft tissue here in the epitympanum. The addutus ad antrum is probably a little wide in here. Mastoid antrum posteriorly is also opacified. And then you can see here, we see the ice cream. So the malleus head is there, but we're missing the cone. So we're missing the body and the short process of the incus. So that's eroded due to this cholesteatoma. On the coronal image here, you can see this is the scutum, which is blunted. Normally you would expect a nice little triangle coming out here. And then you can see that there is this frank defect in the tegmen tympani. And so something like this, we would recommend an MR just to make sure there isn't an underlying cephalocele coming from above, projecting into that middle ear cavity. Here's another cholesteatoma. So these are axial and coronal CT images of the left temporal bone. You can see the nonspecific soft tissue here pacifying the middle ear cavity posteriorly. But again, we see the ice cream, so the malleus head, but we're missing the cone. So erosion of the incus posteriorly here, the body in the short process. And then back here, you can also see there's erosion into the otic capsule and erosion into that lateral semicircular canal. And this is the coronal image. This is the lateral semicircular canal. Again, tympanic segment of the facial nerve canal, cochlear promontory, oval window. So again, you can see that there is erosion into that lateral semicircular canal here. And just yet another image. This one, they told us that there was no prior surgery, and you can see that there's quite a bit of erosion here and frank erosion into the lateral semicircular canal. And then again, these are identical to epidermoid cysts. They have this thick keratin that's going to restrict the movement of water, and so you'll see diffusion restriction with these cholesteatomas. And then this is just another case, very extensive cholesteatoma. You can see this well-defined lobulated lesion eroding much of the temporal bone here. These are two axial CT images of the right temporal bone. And here, this is where the internal auditory canal would be. So you can see it's completely eroding the anterior and posterior walls. It's eroding into the inner ear structures here. Over here on this image, this is the cochlea. And so you can see it's eroding into that, eroding the bony covering of the carotid canal over here, as well as the sigmoid plate bordering the sigmoid sinus over here. So very extensive cholesteatoma. MR, it's going to look like epidermoid cysts, so they're going to be T2 hyperintense. They will not enhance. And again, money sequence is the DWI, the diffusion sequence. These are going to restrict the movement of water, and so you can see bright signal in those areas of cholesteatoma. Now, typically in the initial diagnosis of cholesteatoma, CT is usually sufficient along with your clinical exam. And really, MR is typically not necessary in the first evaluation of a cholesteatoma. And generally, the setting where MR is going to be helpful is in the post-surgical settings. And here you can see this patient's had a mastoidectomy, and there's complete opacification of the mastoidectomy bowl. And we can't tell if there is recurrent cholesteatoma in there or if it's just all granulation, tissue, debris. And so here you can see the MR. There's heterogeneous signal on the T2, but on the DWI, the diffusion-weighted sequence, you can see that there's just a small area, but an area consistent with the recurrent cholesteatoma and the anterolateral aspect of the mastoidectomy bowl. So our standard diffusion-weighted sequence has a lot of artifact, and that we often typically, especially on a brain MR, obtain them at 5 millimeter thick slices. And so we do have a special protocol just for cholesteatoma evaluation, where we do these non-echoplanar sequence type of DWI sequences that have been shown to reduce that artifact. And with this, we also obtain them at 2 millimeter thickness slice images, both in the axial and coronal plane. And using this sequence basically allows us to increase our confidence and detect lesions as small as 2 millimeters. These significantly reduce the artifact found at the air-bone interface. It does increase scanning time, but we typically limit the coverage to just the temporal bone, and so we can still get them in a decent amount of time. And then some other sequences have been developed as well. We also have the resolve sequence on some of our scanners, which has also been shown to provide high spatial resolution and decreased susceptibility artifact to detect these cholesteatomas. This is just a case which was actually a congenital cholesteatoma, but you can see on this CT of the right temporal bone, you can see the ossicles, and there's just this little bit of soft tissue just medial to the malleus head. And this is hard for our neurotologists to see on their otoscopic exam, as you can imagine. And so we just did a non-EPI DWI sequence, and you can see even a lesion this small clearly shows reduced diffusion, confirming that this was a congenital cholesteatoma. Glomus tympanicum is the most common primary tumor of the middle ear cavity, and patients typically present with pulsatile tinnitus as well as conductive hearing loss. And on your otoscopic exam, you're going to see a red pulsatile mass behind the tympanic membrane. These typically arise from the paraganglia associated with the tympanic plexus of Jacobson's nerve, which flares out or fans out over the cochlear promontory. And so this is why we typically see these tumors arising along the cochlear promontory. And you can see how its relationship with the tympanic membrane laterally, which is why you're seeing that red pulsatile mass just behind the membrane. So on imaging, we're going to see, here we can see axial and coronal CT images of the right temporal bone, and we're just going to see non-specific soft tissue in the middle ear cavity. This again is the cochlear promontory over the cochlea, so you can see it right up along the cochlear promontory and laterally abutting the tympanic membrane. On imaging, the differential for us for this would be a congenital cholesteatoma, but these both Glomus tympanicum and congenital cholesteatoma would have a very different appearance on your otoscopic exam. So if you see a red mass on otoscopic exam, a non-contrast high-resolution CT of the temporal bone is usually sufficient because with a red pulsatile mass, the main differential diagnosis is going to be aberrant ICA, Glomus tympanicum, and Glomus jugular tympanicum. And these three diagnoses can be distinguished simply with a non-contrast temporal bone CT. And so for our imaging, whenever we get that indication, we're going to look closely at the carotid canal. So you can see here that there's a nice bony covering between the soft tissue and the carotid canal here. This is an aberrant ICA in contrast, and you can see on the coronal how it just does look like a little bit of soft tissue along the cochlear promontory. But on the axial, you can clearly see how it's this tubular structure that's contiguous with the carotid canal. And then for Glomus jugular tympanicum, you'll be able to diagnose that because we'll look for permeative osteolysis along the margins of the jugular foramen as well as around the jugular foramen and of the jugular plate. And so here we have a jugular tympanicum tumor that's extended into the middle ear cavity. So that's why you would see a red mass behind the membrane. But on the CT, you can see all that erosive changes, which we don't see with the standard Glomus tympanicum tumor. CT of non-contrast CT is also sufficient for mapping out the extent of the tumor. So here again, we would see that it's confined to the mesotympanum, not extending into the hypotympanum, and can basically help you with your surgical planning. So again, MR is usually not needed, but if it's done, these will enhance intensely. Generally with paragangliomas, the larger lesions greater than 1.5 centimeters will have that characteristic salt and pepper appearance that we see with paragangliomas elsewhere. But because these Glomus tympanicum tumors are typically small because they present fairly early with symptoms, we typically don't see the classic salt and pepper with these Glomus tympanicum tumors. And unlike a cholesteatoma, these will not restrict water. There will be normal DWI. Otospongiosis, also known as otosclerosis, is due to deposition of abnormal spongy vascular bone that's less dense than the otic capsule, or deposition of that spongiotic bone within the otic capsule that's less than the surrounding otic capsule. Most commonly, it's seen bilaterally, and there are two types, fenestral and retrofenestral. So fenestral otospongiosis occurs in this location, the Fissula Antefenestrum, which is anteromedial to the open oval window. So in the very beginning of the talk, I talked about going through the stapes. and basically trying to follow it all the way up, scroll up, and then find the oval window at the top. And then every image for our temporal bone, we look as part of our search pattern, just anterior to the oval window to look for this diagnosis, because it's so easy to miss otherwise unless we specifically look here. So again, we'll usually follow stapes, but follow it to the oval window and look just anterior to see if there's lucency where it should normally be nice and hyperdense like the rest of the otic capsule. Now, because this is an expansile spongiotic bone, it'll typically encroach onto that stapes footplate and the oval window and cause conductive hearing loss here. The retrofenestral type is basically going to have a fenestral component, so you'll still see lucency in that region of the fissula antefenestrum, but then you'll see lucency elsewhere within the otic capsule. And here you can see this extra, like this long ring-like structure around the cochlea. It's often known as the fourth cochlear turn sign. It can be anywhere in the otic capsule. You can see it around the vestibular structures as well. So here we have axial and coronal CT images of the left temporal bone, and you can see that there is abnormal lucency within the otic capsule here surrounding the cochlea. And you can see this patient has had a stapedectomy as the treatment for the otospongiosis. And you can see that the stapes has been resected and there's this linear metallic structure going right up to the oval window. Now, one reason that a stapedectomy with a stapes prosthesis may fail is that the round window is also involved. So, you know, we need both the oval window and round windows to be moving well to conduct hearing. And so here in this patient, you can see that there's abnormal lucency surround the cochlea and the otic capsule on the left temporal bone here. And then back here, if we find the basal turn and we look back, we can see that there's actually abnormal lucent bone here that's basically covering the round window. And this is just a normal round window for comparison. You can see how the basal turn goes back and meets air, and there's just this little thin membrane or thin partition. And here we can see there's something in between that basal turn and the adjacent round window niche. And so something like this is something that we would mention as these patients are more likely to fail with a stapedectomy and a stapes prosthesis, because ultimately the round window is not working well here. And then finally, superior semicircular canal dehiscence can also cause conductive hearing loss through the third window effect. It can also cause tilio phenomenon, which is sound-induced vertigo. And this is an extremely simplified version. There's much more nuance than this, but basically, you know, the ossicles are going to cause the oval window to vibrate and then cause fluid to propagate, or these waves to propagate through the cochlear fluid, and that gets released through the round window. And with semicircular canal dehiscence, you've basically created this third window, and that's now going to divert some of those waves away from the cochlea. So it's going to kind of have the same effect as if you move the oval window half as much. And so that's why these patients are getting conductive hearing loss. So shell view is the view, again, that we obtain parallel to the superior semicircular canal. So that allows us to see the canal in its near entirety and really nicely look to see the bony covering of the canal. And here you can see that there is dehiscence of the bony covering here. Stenvers view is obtained perpendicular to the superior semicircular canal, and it gives us this nice cross-sectional view of the superior semicircular canal. And you can see that there is dehiscence as well here in this bony covering. Now, can MRI replace CT in evaluating semicircular canal dehiscence? This was a study done back in 2013 where they looked at 224 ears and 112 patients. And, you know, as expected, well, I guess I should first say this study was basically comparing it to CT. So CT, of course, can also overdiagnose this. Ultimately, it has to be used in conjunction with your clinical exam. But basically, in comparison to CT, they found that there was a negative predictive value of 100%, because as expected, MR is going to not be as good as evaluating bone as CT is. So it tends to overcall semicircular canal dehiscence. So the positive predictive value is not very high. So generally on every MRI, I see exam that has a KISS sequence or high resolution T2 sequence. I'll usually follow the superior semicircular canal and follow it up. And if I see bone above the semicircular canal, I can just exclude dehiscence that way. But if I'm not sure, I can always do the reconstructions. And so here you can see this is a Puschel view. This is the Stenvers view, seeing the superior semicircular canal and cross-sectional area here. And you can see there's nice bone, this dark bone, covering the superior semicircular canal. So if you see this, or if we see this, we can effectively exclude semicircular canal dehiscence on MR. But again, MR tends to overcall it. So if we see what looks like semicircular canal dehiscence, as you see on this patient, both on the Puschel and Stenvers view, we usually just recommend a CT if clinically indicated. And here on the the Puschel and Stenvers CT images, you can see that there is confirming dehiscence of this superior semicircular canal. So again, MR tends to overcall. If we see a nice bone, we can exclude this diagnosis. If we don't, we can recommend CT. And sometimes it's hard, for us, we sometimes just see this incidentally for, some reason they got a KISS sequence on the study, but patient doesn't have any symptoms. So, it's kind of been debated whether or not we really should be recommending CT, but we usually kind of just say, as clinically indicated. So in conclusion, both the oval window and round window need to vibrate in order for those waves to propagate through the cochlear fluid. So, I really try to stress how we have to look at those structures, not just the outer ear and middle ear in patients with conductive hearing loss. Many inflammatory diseases involving the middle ear cavity and tympanic membrane are related to Eustachian tube dysfunction and so are seen together in the same patient. The Fissula Antefenestrum should be part of the routine checklist as you evaluate temporal bone CTs because fenestral otospongiosis is otherwise very easy to miss. And then finally, semicircular canal dehiscence, even though it's an inner ear structure, again, can cause conductive hearing loss through that third window effect. And thank you.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.